Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Usually when we think about fixing like a highly complex mechanical system, say a high-performance turbine or something,
Right.
the whole approach relies on logical isolation. Like a single valve fails, you reach in, you swap that specific valve.
Exactly. You don't just get the machine.
Yeah, you absolutely do not strip out the fuel line, the combustion chamber, and half the exhaust system just to fix one little localized point of failure.
Because that kind of collateral disruption in mechanics would be, well, it'd be considered a catastrophic design flaw, You always want to contain the repair footprint.
But when you step into the theater for hepatopancreatobiliary surgery, that entire paradigm is just completely inverted.
Oh, totally upside down.
We're looking at this physiological landscape where fixing the localized problem actually demands completely dismantling and rewiring the upper abdomen.
It really is a massive undertaking.
So whether you are a surgeon prepping for your board exams, a doctor gearing up for an MDT discussion, or simply looking to refresh your complex anatomical knowledge, this deep dive is custom tailored for you.
Spot on.
Today's mission is unpacking one of the most formidable operations in HPB surgery, the Whipple procedure, or pancreaticoduodenectomy.
It's a mouthful, but yeah.
It is, and it's simultaneously this massive cancer operation and just a wildly complex reconstruction of the foregut. But before we jump in, a quick disclaimer. This content is for reference only. Always ensure you follow local guidelines in your clinical practice.
For sure. And, the duality of the Whipple is really what makes it the ultimate test of an HPB surgeon.
Right.
You are navigating some of the most unforgiving real estate in the human body, where literally millimeters separate a successful oncological clearance from, well, catastrophic hemorrhage.
Millimeters. That's just wild to think about.
Yeah. So our aim today is to kind of bridge the anatomical realities of this space with the actual physiological rationale that drives all these really high-stakes operative decisions.
Okay, let's get right into the unblock resection phase then.
Yeah.
Because before we talk about who needs this, we have to look at the what. And the sheer scale of tissue removed is staggering.
It really is. I mean, you are taking out a lot.
Right. We are talking about resecting the head of the pancreas, the unsighted array process, the entire duodenum.
The proximal jejunum, the distal common bile duct.
Yeah, the gallbladder, and often a variable portion of the distal stomach. Let's unpack this.
Let's do it.
Taking out all these distinct, highly functional organs sounds like massive collateral damage. It's essentially like cutting the power to a shared grid, right?
That is actually the perfect analogy. It looks like arbitrary destruction until you view the foregut through the lens of embryology.
Which most of us try to forget from med school.
Fair enough. But these structures, they don't just happen to sit near each other. They actually develop together from the same embryonic foregut and midgut structures.
Ah, okay, so they're physically linked from day one.
Exactly. And because of that shared origin, they are inextricably linked by a shared power grid, a continuous vascular and lymphatic network.
Right, the pancreaticoduodenal arcades.
Precisely. You have the superior pancreaticoduodenal artery coming off the gastroduodenal artery, and then the inferior one arising from the SMA, the superior mesenteric artery.
And they just loop together.
Yeah, they form this overlapping, redundant arcade that supplies the pancreatic head, the duodenum, and the distal bile duct all at once.
So if you try to, just core out the tumor in the head of the pancreas,
you obliterate that entire arcade. The duodenum instantly becomes ischemic. You just can't save it.
Wow. So the plumbing is so intertwined that you can't save one organ without preserving its blood supply, which invariably runs through the other.
That's the anatomical trap, yeah. But beyond just preventing ischemic necrosis of the duodenum, there is the whole oncological mandate.
The cancer spread.
Right. Because even if you could somehow magically isolate the blood supply, you still couldn't leave the duodenum behind in a cancer case. The lymphatic drainage dictates that.
Meaning the lymph nodes are shared too.
Exactly. The lymphatic basins draining the head of the pancreas flow directly along that shared vascular network and right into the peripancreatic and periduodenal nodes.
Right.
So to achieve an R0 resection, meaning microscopically negative margins, and secure that critical regional lymphadenectomy, the entire hepatoduodenal and pancreaticoduodenal package just has to come out on bloc.
So you leave the duodenum, you leave the microscopic disease.
You guarantee a recurrence, yeah.
Okay, that makes perfect sense and really sets up the parameters for our patient selection. Knowing how massive this anatomical disruption is, the next logical question is, Who actually undergoes this procedure?
Well, the primary mandate is periampullary malignancies.
Right, so mostly resectable pancreatic ductal adenocarcinoma, PDAC of the head and unsick process. That's the main one we see in the data.
By far the most common, yeah. But we are also dealing with distal cholangiocarcinoma, ampullary carcinoma, and duodenal adenocarcinoma.
So the pathology kind of dictates the long-term survival, but the anatomical location dictates the intervention.
Exactly. They all converge at the ampulla of Vater. The histology of the primary tumor matters immensely for the adjuvant therapy pathway. Like ampullary tumors typically have a much more favorable biological behavior than PDA.
Oh, definitely. PDA is notoriously aggressive.
Right. But surgically, the rule of the region applies here. If the disease is localized in that crossroad where the bile duct, pancreatic duct, and duodenum meet, the Whipple is the only potentially curative option.
There is literally no lesser surgical alternative for a cure.
None.
Okay, but here's where it gets really interesting, but also a bit perplexing. I want to push back on the indications for a moment.
Okay, go for it.
Because the sources also explicitly mention benign or inflammatory diseases, things like chronic pancreatitis with an inflammatory head mass or complex trauma.
Yeah, that's true.
But the sources explicitly mention substantial morbidity things like leaks, delayed gastric emptying, and pancreatic fistulas.
Yeah.
If the risks are that high, how do we justify doing a Whipple for benign disease?
It's a great question, and it requires a serious, careful risk-benefit analysis. The threshold to operate for benign disease is purposefully towering.
So you aren't just handing these out to anyone with a bad pancreas?
Definitely not. You are weighing the substantial physiological toll of the surgery against a patient whose quality of life has already been completely eroded by disabling, intractable symptoms.
Like severe narcotic-dependent pain.
Exactly, or an inflammatory mass causing recurrent biliary or duodenal obstruction. And you only do it when lesser radical drain-type procedures like a Frey or Puisto procedure are totally unsuitable.
And obviously when their general operative risk is acceptable.
Right, which ties back into the standard selection criteria for malignancy too. You need an absence of distant metastasis, no encasement of critical arteries like the SMA or coeliac axis, and a generally good performance status.
Yeah, and you touched on the morbidity. The postoperative pancreatic fistula, or POPF, is the big one. That's a major reason we hesitate.
It is the absolute Achilles heel of the operation. The mortality of a Whipple has dropped, below 5% in high-volume centers, which is great.
But the morbidity?
The morbidity still hovers around 40%, heavily driven by those pancreatic fistulas. Because think about it, in a healthy pancreas, or one that hasn't been fibrosed by chronic obstruction, the gland is incredibly soft.
I think I've heard it described as having the consistency of wet oatmeal.
Yes. Wet oatmeal. Now imagine trying to sew wet oatmeal to a loop of jejunum.
That sounds literally impossible, a total nightmare.
It is, and if that anastomosis leaks, you aren't just dealing with inert fluid, you are leaking inactive pancreatic enzymes into the retroperitoneum, which then become activated by enterokinase from the bowel.
Oh, wow. So they basically turn on.
Right. And those activated proteolytic enzymes will actively digest the surrounding tissues. They digest the retroperitoneum, and most terrifyingly, they will erode the stump of the gastroduodenal artery,
leading to a massive delayed hemorrhage.
Exactly. Catastrophic post-pancreatectomy hemorrhage.
Oh, man, that paints a very clear picture of why patient selection is so rigorous.
Yeah.
Okay, so once you've selected the right patient, the surgeon has to choose the specific technical approach.
Right, the reconstruction phase.
Yeah, because the oncological principles remain the same, but the reconstruction differs. The literature heavily debates the classic Whipple versus the pylorus-preserving pancreaticoduodenectomy, or PPPD.
Yeah, the classic versus PTPD debate is a classic itself.
So why would a surgeon choose PPP over the classic? Is it just about keeping the stomach intact, or does it actually work better physiologically?
Well, the intention behind preserving the pylorus and a small cuff of the proximal duodenum is to improve gastric emptying.
Yeah.
You utilize a duodenojejunectomy instead of a gastrojejunectomy.
Okay, keeping the native pump.
Exactly. The theory suggests that keeping the native antropyloric pump will maintain normal gastric emptying mechanics, preventing things like dumping syndrome.
But looking at the data, delayed gastric emptying, or DGE, still happens regardless, right?
It does. That's the big caveat from the sources. Saving the pylorus doesn't automatically solve the emptying problem.
Why is that? I mean, the valve is still there.
Because the pathophysiology of DGE is multifactorial. When you perform the resection, you are disrupting the vagal innervation to the antropyloric region.
Ah, so you lose the nerve signal.
Right. And you are also removing the duodenum, which is the primary source of motilin, the hormone that actually stimulates gastric motility.
Oh, so you lose the nerves and the hormone.
Exactly. Combine that with the local inflammatory milieu of the retroperitoneum, especially if there is a subclinical pancreatic leak and the stomach essentially becomes paralyzed.
So local inflammation basically shuts the whole system down.
Exactly. So PPD isn't a magic shield against DGE. And importantly, the classic Whipple is still absolutely preferred and really mandated when there's gastric involvement by the tumor. You can never compromise the oncological margin.
Never for a functional benefit. Makes total sense. We should probably also mention that minimally invasive techniques exist now too, right? Like laparoscopic or robotic approaches.
Oh, definitely. They adhere to the exact same oncological principles, but obviously utilize keyhole access.
But those are usually confined to specialized high-volume centers, aren't they?
Very much so. The reconstructive phase in a robotic Whipple, particularly the pancreaticoduodenectomy, requires a level of suturing dexterity that has an exceptionally steep learning curve.
I can imagine. Okay, so to truly understand the Whipple for an exam or an MDT, you have to really visualize the flow of the operation in the theater.
Let's walk through it. It really helps to deconstruct the phases.
Yeah, let's do a high-level walkthrough. Step 1 is exploration, right? Laparotomy or laparoscopy to exclude metastases.
Right. This is the first critical decision node. If you find tiny peritoneal implants or a liver lesion that the CT missed, the curative intent is lost.
So you pivot to palliation right there.
Exactly. You spare the patient the massive insult of a resection and maybe do a bypass if they are obstructed.
Makes sense. Okay, step 2. If the abdomen is clear, you move to the Kocher maneuver. This is a wide mobilization of the duodenum and pancreatic head to assess SMA involvement.
You're lifting everything off the retroperitoneum to feel that posterior relationship with the major vessels.
Step 3 is vascular control and division. Dividing the common hepatic duct, doing frozen sections on the proximal margins for cancer, and the lymphadenectomy.
Right. You need pathology to confirm that bile duct margin is clear before you even think about reconstructing.
And step 4 is the gastric or duodenal division, depending on whether you're doing classic or PPPD.
Exactly. Separating the specimen from the upper GI tract.
Which brings us to step 5. And I want to stop here for a second because this is the crux of the dissective phase. The pancreatic neck transection and uncinate dissection.
This is where things get tense.
Yeah. So what does this actually mean for the surgeon's stress levels? Because dissecting the uncinate process off the superior mesenteric vein and artery sounds literally like diffusing a bomb.
That is a very apt analogy.
Like one wrong snip and you're dealing with major vascular consequences in a very deep hole.
I often confirm to trainees that this is usually the most technically demanding part of the surgery.
Because of the vascular proximity.
Exactly. The uncinate is tethered to the SMA and SMV by a series of very short, fragile venous and arterial branches, specifically the inferior pancreaticoduodenal vessels.
And they are tiny.
Rear millimeters long.
Yeah.
You cannot just clamp and cut en masse. You have to individually isolate and divide every single tributary. If you pull too hard, you avulse a vein directly off the sidewall of the SMA or SMV.
Oh, man. And that means instantaneous massive bleeding.
Right. In a very confined space. It is technically exhausting.
Okay, so assuming we diffuse the bomb successfully, steps 6 and 7 are the removal and reconstruction. The specimen is removed on bloc, and then you have to rebuild the plumbing.
Right. Usually on a single jejunal loop or roulim.
And the order of that is kind of surgeon-dependent,
Okay.
but generally it includes the pancreaticoduodenostomy, hepaticoduodenostomy, and then the gastrojejunectomy.
Yes. PJ, the HJ, and the GJ.
And the golden rule for all of these anastomoses.
Yeah.
They must be tension-free, well-vascularized, and leak-resistant.
Absolutely. Tension is the enemy of perfusion. If you pull that jejunal loop too tight, the microvascular blood supply fails, the tissue necroses, and the anastomosis breaks down.
And as we said, leaking pancreatic enzymes is bad news.
Very bad news.
Well, this has been an incredible breakdown. To summarize why the Whipple is so vital for medical professionals to grasp, it really demands an integration of complex imaging, intense MDT collaboration, and an incredibly high-level understanding of upper abdominal anatomy.
It really is the pinnacle of foregut surgery.
It is. And it offers the only curative hope for many periambulary cancers.
You know, it leaves you with a really fascinating thought to ponder, based on the source material we review.
Oh, what's that?
Well, given that the Whipple is the only potentially curative option for these cancers, but carries such high morbidity with those leaks and fistulas, it forces us to continually ask a tough question.
Which is,
where is the line between achieving aggressive oncological clearance and risking an unacceptable quality of life cost for the patient? Especially now, as neoadjuvant therapies cause such dense desmoplastic reactions, making the surgery even harder. As we refine patient selection, navigating that boundary is truly the art of HPB surgery.
that is such a profound point. We are pushing the limits of biology and mechanics at the same time. Well, if you like this content, then do not forget to share it with at least one of your colleagues or friends and spread the word. Also, check out our YouTube and other social media pages. And do check our previous season and episodes with some very relevant topics. Keep learning, and we'll catch you on the next deep dive.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.